right. So you can see us here back from this room with the,
Pedro Moreno.
Yeah, Pedro on the left side and of course my fellows on the right side here. And we are ready to start with the case number 2, 89-year-old who presented with a typical chest pain and had a abnormal stress echo with multivessel ischemia, EF 56%, but has moderate MR. Patient had the cabbage in 2016, had also had a pacemaker, but at that time 3 grafts were done. Lima to LED, vein graft to RCA, and vein graft to OM. And basically reset angiogram showed, which will show basically the Lima is good, vein graft to RCA is good, and the OM graft is gone and has a very complex disease of the left main, although it's a protected left main now, with a proximal circ and bifurcating LPL and OM. So Pedro, you can show that angiogram now.
Go ahead.
Yeah.
Play it there.
Yeah. Play it from there. Yeah.
So we did an angiogram to look at the groin, and it's a good size for an Impella. And as you see, we have calcification in the distal portion of the left main, which is severe. You see the tram rack there.
No, hold on a minute. We're not seeing anything. Show us first the angiogram and
just
give
let
us a
know.
good reason why you've chosen to go to LP support.
Yes.
Do you see it now?
Yeah.
Okay, so previous picture. Yeah, this is the picture.
Yeah.
So we have distal left main calcific, about 80% into the bifurcation that is respected. Then the proximal circ has disease, as well as the first OM that is a trifurcating vessel, giving the whole lateral wall, superior and posterolateral wall blood. So you see that the disease extends diffusely and segmentally into the third branch of the OM. Let's see it in the aerial caudal, as you see it there.
And see the very big right the circumflex RCA PDA graft is there, but supplies maybe 5% of the myocardium, and patient has a moderate MR. So the question basically was, with a normal ejection fraction, do you need to use a support? So I think this is kind of a case. We decided, compared to the earlier patient, here there's a good femoral artery that we support, and we are going to show something very innovative which is done with the Impella CP. So if we can show that.
Show us the groin.
So before you go to the Impella CP, Dr. Sharma, I'm seeing a very, very good blood pressure. I see a good EF. I see a patent Lima to the LAD. I see a not such a difficult for this lab to perform this left main intervention. And I challenge you, just because he's got great legs, he shouldn't be getting support if this is what we're going for. So show me the reason why and the evidence why you would actually need support in a case like this, as opposed to the earlier case where there was slow flow, severe calcification, and you guys didn't use any support and did perfectly well. I probably would have used it in case 1. In here, I'm very, very, very puzzled. Right. So before we even go there, let's make sure that I'm not crazy, that maybe the panel thinks otherwise. So let's start with John LaSala.
Well, I can share your skepticism. However, I'm sure what we're going to hear from Dr. Moreno and Dr. Sharma is that they possibly are concerned about the degree of mitral regurgitation and the potential for ischemic MR resulting from that. I think that's the only compelling reason right now for going ahead with support.
And that is it.
Most of the time, if you had a good right corner, you
Yeah.
wouldn't have that issue, and you go ahead and do it without support.
And this patient, you are right. This patient also, during abnormal stress echo MR, which was 2+, increased further. So that is one of the reasons in this particular case, absolutely. Can you do this case without Impella? Answer to that is absolutely yes. But what is the disadvantage? And we know that FDA approved for normal ejection fraction with a complex anatomy. This case actually was even presented to surgical colleagues, and they said, since Lima is patent, nothing need to be done. You guys do the intervention. And based on only indication here is that potential hemodynamic compromise from increasing regurgitation in very complex left main, circumflex, and trifurcating OM and LPL.
Okay, any other comments from the panelists?
I think the other thing you could do is, of course, get hemodynamics in both cases. And so one other thing to just get yourself some more information is to understand what the filling
LVN
pressures are
right.
and what, so that you can be understanding that. And maybe you even do that if you're putting the Impella in to see as you're going through it what your advantages are.
Yeah, so what was the,
What
that's
were
a
the
very
EDPs?
good thing. What was the LVEDP when you went in,
ADP
Pedro?
was 14 to start. And-
Not too bad, yeah.
Not too bad. So let me show you. One of the things that you use when you use the Impella, you need either radial or another axis, sometimes 7 French. So we are using this new approach. I don't know if it's been seen right now. Please, I need the camera here in the groin, please. Camera on the groin. Yeah.
Yeah, we see you. We see your we
Okay.
see your hand on the groin.
Okay, good. So you see the 7 French introducer through the Impella, which is 9 French, and even though this is 14 French, you can do both. Now you have to be careful about this because it can bleed. So if you have a lot of bleeding, it's not appropriate to do it. Even the company is not highly recommended it. However, I've been doing it successfully and following the hemoglobins after the day after, and it's been good so far. So far so good. We use a VL30, and this is a short lady, and we're gonna go with the Rota
French.
now. 7 French, yeah.
And,
Okay.
and see the calcium, same, severe calcium, we are ready to go, speed has been checked, and 1.75 Rota Pro.
Okay.
Can everyone appreciate the angiographic calcium? And then, of course, the calcific aid is up there as well. We really want you. You can follow it actually on your own app. You know, go to the App Store, download it, put it on your phone, and follow the case using so that you could get a very good feel on how to use this aid as we're moving forward. So, okay, yes.
Roxana, a quick question.
Yes.
Pedro, do you pre-close?
Yes, absolutely. I do the same TAVR approach with 2 pre-closes on the 9 French to start with.
So same, it's 3 steps. We are doing a Dynaglide tap, which is good, and let's start the Rota now. Good.
Okay.
Yep. We're ready to start here. Now question was, we didn't use an Impella in the previous case also, patient's body weight. This patient, ideal body weight, good vessels, that also prompted us that let's use an Impella, but you're right. Is it absolute necessary by my algorithm? I would say no, but it's not contraindicated. That's the only point I want to make.
So I think the other thing that everybody wants to know is how do you choose the burr size? That's such a controversial. You ask 5 different people, you get 6 different answers. So how did you choose the current burr size, Dr. Sharma?
I would say very simple. You decide 1.5 or 1.75 based on the vessel size, the lesion length, and so. That's it. That will take care of your 95% of your intervention. Show the hemodynamics. The blood pressure has gone down even with the Impella to about 80.
Yeah, let's go with the Neo, please.
Give the neo. Yeah. Although with the Impella, it's less of a important because part of the blood being ejected by the Impella, but key is just to say from 180, blood pressure has gone down. So let's finish the polishing of the left main and circumflex. Good. And the point was made by Dr. Keeney also, good. That key is that you don't need to go to the bigger burr unless it is necessary. Go. So what we'll do is that put a wire side by side, dilate the vessel, and if it can expand, you don't need to go to the bigger burr and only go to the bigger if necessary. But otherwise, 1.5. Yeah.
So did you guys get any ischemic MR there?
Well,
Wow.
we're not doing the echo.
It'll be
have
hard
the
to
PA
know, right,
pressure.
with
Yeah.
Impella on board.
Yeah.
Yeah.
And we don't have the PA pressure, which should have been in actually.
Yeah.
Yeah. Well, I mean, yeah,
Okay.
yeah, good. Okay, so now we are ready.
Looks good. Blood pressure is
Let's-
excellent.
Yeah.
Yeah, Neo.
So let's take a picture now.
So your plan would be to take the Impella out at the end of the procedure, right?
Always, yes.
Always.
Absolutely.
Yeah, even in the Protect 2 trial, we were the
Let's exchange. I
yeah.
want to put the filter.
So
We'll
we're
side
going to
by
have
side.
Because it was
everybody,
difficult
you know, the most important keynote lecture here is going to be on these support devices by Dr. Bill O'Neill. We're so excited about that. So we'll hear it from him and why he would or would not. Maybe he'll comment on that. I know he's here
Give me
in the
wire
audience.
introducer. Hi, I have it.
Yeah.
Okay.
Okay, so
this looks
is,
great.
Yeah, so now we are going to put a wire side by side into that from left main. Now question is, should you exchange versus side by side? A lot of people will exchange, but we say that once a good result, you're okay to go side by side.
Okay,
And we have the balloon ready. What balloon we have?
Where's the fluoro?
Did you go through that OM lesion? Because I didn't.
No,
I
there
didn't
we
see
just
that.
stopped before
Yeah.
that. Yeah, because remember there's no calcium in that area.
Okay.
So calcium is only in the left main and proximal circ.
Okay. But why not go through that while you're there?
Well, I mean, again, the question is, it's a very angulated and it may create a problem in terms of wire bias, although many times it is towards our benefit. But let's show now, if there is a problem in advancing, you can always go. Yeah.
So I think for this left main, Dr. Sharma, would you consider any scoring balloon as opposed
Yes.
to rudder
Yeah,
blade?
yeah.
Absolutely.
for sure.
Yes. So this one will be,
There's a tough
huh?
wire in here.
Okay, if the tough wiring, you can leave this wire into the OM and we'll put a wire into the LPL, the over-the-wire system and change it to the LPL, right?
Would this be a good candidate for a shock wave, Roxana, for the left main?
Oh, I'd love to hear. I don't think he thinks that number one. So three questions. So for the circ lesion, you don't think it's calcified, so you'll be able to open it with a regular pre-dilatation balloon, I think. The question on the table here is rotoblader, shockwave, orbital atherectomy. Why did you choose rotoblader over all these two other techniques, Dr. Sharma?
Yeah, the question is, remember the only some data with a disrupt CAD2 presented. So can this case be the trial ongoing at present? Only problem still will remain for all these comparative devices that there is no comparison. So with a disrupt CAD, it's only the using the shock wave. The control arm is not atherectomy.
Okay.
And same thing in the Eclipse. They're doing orbital atherectomy, but the control arm is still balloon, not another atherectomy or the shock wave. But as such, the data point of view, I think this one probably will be an okay case as far as I know with the literature, with a shock wave. And of course, we can find out from the audience, our panelists who have used the shock wave, will that be okay for this case? But I'm sure Abhijat probably has the experience also, right?
Yeah, I think that the challenge is when you cannot cross the lesion, but I bet that with this big left main, shock wave would be a good option.
I'll help you here.
Yeah, so what do you got there?
So now,
Yeah, is that an angiosculpt? What is that?
No. Right now, what we did is
Fine cross.
the fine
Fine
cross
cross.
to change the wire into the lower branch. Remember that lower branch was very angulated. So your question was, why did we not go with the rota into that area? Was clearly because of the angulated
Angulation,
vessel.
yeah.
And there was no calcium. Now, if you have angulated and calcium, you have to end up in using that time. I would have gone with a 1.25 or maybe 1.5 bar, not 1.75.
It's a big vessel.
Yeah.
One of the other key differences here, of course, is after rotoblader, we're usually not following up with a standard balloon, but at the very least an NC balloon, or as you said, specialty balloons.
Right.
Whether you want to use a cutting balloon, whether you want to use a chocolate
As long as
balloon,
wire.
et cetera. Alex, you've got more experience with shockwave and the coronaries. How about following up with that after rotobladers? Any merit to that idea?
Well, I think what we learned from rotoblader is that we certainly have more acute gain, right? Because you modify the plaque. But there is no real impact at long term. So this is what the data says.
No, I think his question is interesting, though, Alex. He's saying after rotational atherectomy, would you put a shockwave balloon now into the
no,
area?
no,
would
no,
you
I-
even
no.
have any idea that
No,
would do
I
anything?
would put a non-compliant. I'm sorry. I would put a non-compliant.
Yeah.
I thought that you asked the comparison between the
Dr.
two.
Colombo, do you go with, you usually use cutting balloon a little bit, no?
Yes, I would consider cutting balloon in the left main. You have to be careful at the ostium of the circumflex in the angulation, but shock wave is a possibility, especially if the vessel is big and you have a lot of calcium. With rot ablation, you really never get very good results.
I didn't see any dog boning on that. There's the lesion. So that dilated nicely.
Yeah, dilated very nicely, and now we are going to do a proximal circ to left main. This
What
is the
size is
2.5.
this balloon?
It's
What
a
size?
2.5.
3.5?
No, 2.5.
2.5, yeah.
2.5,
that
20.
looks-
Yeah.
opening nicely.
Yeah. So clearly, this case for the left main, we'll use a 3.5 or 4.0 Wolverine to open it up further. Yes.
I think for the left main, the cutting balloon is a good idea.
So you would also, so that's a good approach. And then, I didn't really see so much of a need for the full circumflex and OM to be fully dilated. I saw a very focal lesion in that circ, but now it looks like, are you committing yourself to stenting a long segment there or no?
No, I think you can to put a 2 stent, one from the proximal circ to the left main, and second into that OM. The branching OM, but although the superior branch of that OM may need to be taken care. We are going to take a picture now, and let's a little magnify it so everybody can see better.
Roxana, the point about which burr size to choose sometimes is often influenced not only by the length and the severity of the calcium and the severity of the lesion, but also the anticipated wire bias.
Yeah.
In some cases, if it's straight ahead, 175 is better, but here you can see the wire bias coming around. You would generally use the 1.5 burr on this.
2.538.
Yeah.
It looks like
2.533. No, before
Yeah.
bifurcation. Yeah.
the ostium of that distal OM is pinched, but
Yeah.
again, hopefully it'll remain open and
Yeah.
you won't have to do
Exactly.
anything there.
Yeah. Although we can get a 2.5 balloon back again for the ostium of the OM LPL we opened.
Yeah. No, we're gonna open.
Yeah.
So the second ostium we are going to open. No, this is the long. This is the short. Short is the.
Yeah, they're short.
Oh, no.
So you have, Dr. Sharma, based on our agenda, we have, it's 9:40. In 5 minutes, we're supposed to go into our digital session. So you
Wow.
still have another case. So how's this going to work?
Let's see. Are they ready in room 1? Can you find out? Yeah. So we'll let you know in few minutes. We are 10
I
minutes
just want to
behind.
keep you
No.
updated.
Has to be, yes. We are 10 minutes behind in our start time. So we should be able to finish that. So key is we are opening that branch. So same provisional stent. We try not to do a second because both the branches were diseased. So the same 2.520 balloon we are using here. Okay.
Okay, I'll finish here. I'll put 2 stents.
Yeah, so we'll do it now. Yeah,
Yeah,
good.
okay.
Let's get the
Okay.
stent ready. Yeah. So we are using a synergy stent. Any reason for synergy in this particular case? Yeah, or there's nothing special. Any stent, I would say, all stent will be equal. In this situation, only question remain for the left main that we really need to have some more data. We know the data for Excel quite a bit, but whether we have equally good data for other non-Zions type of stent in the left main. So this is now, it's a 2.532 synergy, which will try to do that OM going with the branching OM going into the LPL, and then we'll put a 3.532 also into the left main to the circumflex, and then you can go to room 1.
Okay, so anyone has any thoughts about stent types in the left main, that one versus the other, or are they all kind of equal and you can just close your eyes and pick one?
Well, without any data, what I say that now with the Onyx 4.5 and 5.0, there is a trend towards using more Onyx than other devices, but I think that all the other stents should equally perform well. And
So you have those sizes in Synergy now, too.
yeah, so I don't think there is any difference.
Anyone else? Antonio, do you choose
I
anything?
agree
And
with Alex. I
Eve?
think
I agree.
there's no reason to.
But the only trial that has gone after, though, is Excel. So let's not disregard that either. I think that's what Dr. Sharma was saying, although he's using Synergy. I'm not understanding. So you're gonna go to a Zions in the left main or not?
No, we'll do the same. I mean,
Okay.
To me, same for your database. You have the same stent, so that
Exactly.
your
Once you start
calculation is
with one
simpler,
stent,
yeah.
you stay with that stent.
Right. So now we are going to put a stent from the left main to the proximal circ, and this will be a 3.5. And you can see side branch is good. We are taking the wire out of the side branch.
Yeah, it looks really good.
Yes. And this is a 3.528 synergy now. And of course, it will require few kissing balloon dilatation later.
Yeah, and you
to cross-
haven't dilated that you haven't post-dilated that distal stent yet, right?
Not
or
yet.
did you?
Yeah, that we can do later, yes.
Yeah, let's
back
not
on the
forget
wire,
that.
go back on the
Okay, is room 1 ready? I'm sorry.
No, but let's put this stent, and then
Okay.
you go to there, yeah.
Okay.
That also the first morning theme was left main. Although
Yes.
this one was the protected left main, it's not truly, you know.
It's a good
you
theme,
can say
though.
little cheap.
Very
Yeah.
good theme. Calcific left
Yeah.
main so far. That's incredible. One with Impella, one without. The first one was very tough. This one also. Beautiful work.
Wire first, distally. Advance the wire a little more. The key is the same, making the angle issue. Yeah. So two things. You have to advance the wire, distally give you the body, and if need to be a second wire.
Yeah.
But good,
worry,
good,
worry.
good.
You got it.
Remove the other wire.
Yeah.
Just show us how you're going to position that, Pedro,
Yeah.
nicely
Yeah.
to our audience,
back, pull
please.
back. Pull
What
back,
you're
yes.
using, what markers,
So-
how are you making sure they overlap, all that.
All right, so you overlap at least one cell.
No, but, yeah.
remember this, the dot is actually outside the stent. This
Yeah.
is the key with these stents.
Guide
so
out, guide
you
back.
have to be on the safe side distally so you don't miss the
But
overlapping
most
segment.
important is to cover your lesion in that left main.
Very good.
Yeah, exactly.
Yeah?
Now,
Yeah,
now
there.
we're perfect. Yeah, go
Perfect.
ahead.
Go.
Deploy.
Now, since you are covering stent to stent, usually we go 16 atmosphere. Here you can go 20. Good.
Okay. And now you'll go in and dilate that.
Yeah.
Yeah.
But remember, this is much bigger balloon, right?
So now
So
what we are
just-
going to do is we
just
are
the
going to
overlap
push dilate
segment.
with a 3O, higher pressure.
Yeah, the only technical detail that I would avoid there is to do overlapping at the site of the side branch,
Yeah.
the AV
Yes.
branch.
Which is
Absolutely.
they always
Very good
care
point.
for that. I know
Yeah.
that in the lab, we're always careful that that overlap is not at the side branch based on everything we've learned.
Pull back. Yeah. So and let's take this picture.
Sorry
So
about
you can
that.
get ready. Yeah, that's okay. Guide a little bit out.
Yeah.
Good. That's fine.
Okay.
Ready?
Okay.
No. Guide has to be a
Sorry.
little bit out.
Yeah, Laura. Okay.
Not so much out.
Yeah, that's a little too much out. The same thing that is really jumping.
Okay, now we're
Now,
good.
that's
Okay.
good.
Okay. All right.
Beautiful.
All
Beautiful.
the branches are there.
Excellent.
You're ready
Great
to go
job.
to room 1.
So let's make sure you do the post dilatation. You'll
Yes.
IVIS all of that.